Thank you so much for the opportunity to speak with you all about something that I am very passionate about, which is HFpEF. As you all know, heart failure is a growing public health concern with a projected prevalence that continues to rise and is expected to impact 8.5 million Americans by the year 2030. When we think about HFpEF specifically, this disease accounts for 50% of heart failure cases, as you heard. It increases with age and has a greater prevalence in women compared to men. Outcomes in heart failure with preserved EF are equally poor compared to heart failure with reduced EF, with high 5-year mortality and a greater proportion of non-cardiovascular death compared to HFrEF. And yet, despite the growing prevalence of heart failure, HFpEF remains underdiagnosed, particularly in women, as you heard. Some of the reasons for this include a diagnostic bias, symptom attribution, whereby fatigue or dyspnea are frequently attributed to other comorbidities such as obesity or menopause. There are nonspecific signs, such as, for example, HFpEF symptoms can often overlap with lung disease or frailty. As you heard, there's underrepresentation notoriously in women in clinical trials. And there are differences in imaging. There's limitations in imaging interpretation. So a normal ejection fraction can often be misinterpreted as a normal heart. So there are many traditional risk factors for HFpEF that are common to both men and women. And these often cluster together, including obesity, diabetes, hypertension, coronary artery disease, and smoking. But these risk factors often impart greater risk for HFpEF among women compared to men. So, for example, 60 to 80% of individuals with HFpEF have obesity, but postmenopausal women exhibit an increase in visceral adipose tissue, which is thought to be more metabolically active. In addition, women also have more epicardial adipose tissue, which is a large contributor to HFpEF. Diabetes is associated with a 5 times higher risk for HFpEF in women compared to a 2.4 times higher risk in men. And hypertension is associated with a 3-fold higher risk for HFpEF in women compared to a 2-fold higher risk in men. And women also have more evidence of microvascular dysfunction, which is highly implicated in HFpEF. And then there are also sex-specific factors that predispose women to HFpEF, such as the reduction in estrogen that occurs with menopause, the higher prevalence of autoimmune disease and associated inflammation, infertility and pregnancy-related complications, as well as the higher risk for HFpEF in the setting of both cancer and as a result of cancer therapy. So the symptoms of HFpEF are largely related to fluid accumulation, and these include dyspnea, orthopnea, lower extremity edema, abdominal distension, and exercise intolerance. And these are oftentimes similar in men and women. But compared to men, women often have higher rates of dyspnea on exertion, exercise intolerance, and lower extremity edema. And women with heart failure, as you heard, also report worse quality of life, including lower KCCQ scores and higher Minnesota Living with Heart Failure scores. And in addition to that, we know that women often delay seeking medical treatment compared to men and can often wait for more severe or frequent symptoms to occur before attributing them to cardiac disease. So why might women with HFpEF exhibit greater exertional symptoms? This was a study that was done by a group in Australia that included 161 patients with HFpEF, 71% of whom were female. And they looked at the differences in invasive hemodynamics and structural parameters with exercise. They found that peak exercise workload was significantly lower in women compared to men. The rise in pulmonary capillary wedge pressure when indexed to workload was significantly greater in women, and women had higher lateral E over E prime at rest and with exercise. Women also had higher PVR and SVR at rest and with exercise, as well as lower systemic and pulmonary compliance at rest and with exercise. Women had higher systolic blood pressure at rest, higher exercise mean arterial pressure, And mixed venous blood analysis showed a greater rise in lactate index to peak workload in women compared to men. This was a study that was performed at Mass General examining resting and exercise gas exchange and hemodynamics using invasive CPET among 295 individuals with HFpEF, 59% of whom were women. And despite a lower burden of cardiometabolic disease and a similar percent predicted exercise capacity with exercise, women had lower peak VO2 and mean peak workload. Measures of gas exchange were consistently worse in women, including maximum voluntary ventilation, breathing reserve, and ventilatory efficiency. Women had lower stroke volumes, heart rates, and thick cardiac output augmentation with exercise, as well as worse diastolic reserve and LV reserve. And women also exhibited lower peripheral oxygen extraction. There are other important differences in cardiac structure and function noted on echocardiograms of men and women with HFpEF. Among 279 participants enrolled in the Paramount study, 57% of whom were women, after multivariable adjustment, women had higher indexed LV wall thickness with a trend towards more abnormal LV geometry compared to men. LV diastolic function was more impaired as reflected by lower E prime, higher E over E prime, and greater LV diastolic thickness. And despite higher LVEF in women, S prime mitral velocity was lower and LV systolic stiffness was higher in women compared to men. And I just want to briefly also touch on natriuretic peptides. So in the general population, women have higher levels of NT-proBNP compared to men. The precise mechanism for this is not very well established, but it's thought to perhaps be related to differences in sex hormones. And there's also evidence that the inverse association between NT-proBNP and obesity that we know to exist is actually more pronounced in women compared to men. However, despite the sex-related differences in the levels of natriuretic peptides, the performance of these peptides for diagnosing heart failure and also the prognostic utility is actually similar in both sexes, and currently sex-specific cutoffs are not recommended. So in conclusion, what are the clinical clues that might raise suspicion for HFpEF in women? When you see perhaps an older woman with hypertension, obesity, exertional dyspnea, in the setting of atrial fibrillation and unexplained exercise intolerance, elevated filling pressures or left atrial enlargement despite a normal ejection fraction, recurrent shortness of breath, hospital visits without a clear pulmonary etiology, and disproportionate functional limitation relative to objective findings. With that, I will turn it over to the next speaker.
Yeah, that was a great discussion. Just kind of a few questions that I had. Are you often exercising these patients that are coming into your office to try to elicit diastology and diastolic dysfunction? How often are you doing that, or how are you kind of going about that?
Yeah, that's a great question. There are a few different scenarios in which I do routinely send patients for a right heart cath with exercise. Some situations might be, based on if there's, the patient is presenting with exertional dyspnea, there's a high suspicion for heart failure with preserved ejection fraction. And, maybe in some cases, the patient themselves sort of wants additional, diagnostic proof, so to speak, before, being willing to engage in medical therapy for HFpEF. So in that setting, I can often use it, explaining that having these objective measures of elevated filling pressures with exercise, the hemodynamic definition of HFpEF is theoretically the gold standard. Or when there's uncertainty in my mind if the patient has a pulmonary symptoms, a high suspicion for pulmonary hypertension, and I'm trying to distinguish, how much of this is perhaps pulmonary hypertension or, being primarily driven by LV filling pressures and exercise limitation from HFpEF, I find it's incredibly useful in that setting as well.
Yeah, and I agree. And I think as we get more kind of advanced imaging quality testing, I think that may also minimize some of the needs to do more advanced, like invasive testing as we move forward. But certainly, it's still a very valuable piece of information as you had really good data on the right heart catheterizations. And then the other is how we get people into our clinic in the first place. And how, I think just as we're trying to make it clear to primary care physicians and other points of contact that there may be more to the story of what when somebody has complaints of fatigue and shortness of breath. And are there any particular things that you all are doing in any of your centers to try to help kind of bring that forward?
Yes, that's also a good question. I think part of the trouble, that we have with heart failure with preserved ejection fraction is that these patients often have so many comorbidities. And, in my mind and in practice, I often sort of imagine and see that these patients are not necessarily being seen by cardiologists or heart failure specialists. They're oftentimes being seen by the nephrologist managing their kidney disease, the endocrinologist managing their diabetes, a weight management specialist, sleep medicine experts. So, they're sort of out in the community seeing perhaps many subspecialists and in addition to their primary care provider, but not always a cardiologist or a heart failure specialist that might not be sort of thinking about how all of these comorbidities are, and this in the setting of exertional dyspnea and, clinical signs and symptoms of heart failure are sort of coalescing into a diagnosis of HFpEF.
Yeah, I think that's exactly right. I think as you get more and more subspecialties, it's harder to take the big picture into account and say, hey, there may be a diagnosis that may kind of tie these things or be because of these things that are all added up.